Hi, my name is Ann Robson. I am the Vice President here at Red Oak. I'm going to be doing a presentation on trauma-informed care and putting it into action. I want to talk to you guys about putting trauma-informed care more into practice in your settings. But first, let me find out about you. You folks all work at some level at Grace House? Work, volunteer, do something at Grace House? Okay, good. So I see a lot of RN, LPN, MD. Is there anybody else in the room that has a different function? Social worker, counselor. Good. If you, any other professions in the room? What do you do?
Marketing.
Awesome. I don't know what we'd do without you folks. You make it better. So, awesome. Okay. Let's get started. One of the most important things I think we can do when we conduct a meeting, a program, presentation, anything when we start is give everybody a chance to get here. I think I talked to you before. We know that probably 70% of the people in this country have at least one traumatic experience. That's a huge number. So that means at least 70% of the people in this room today. So we want to make sure we recognize that everybody has a story, and everybody needs a moment to be here, right? You probably raced here. Your hair was on fire, every red light. But when you come into a room, you feel like, I did everything I possibly could to get here on time. I'm not going to cry. I'm going to be okay. But then you get here and you just need a minute to get yourself together. Right? I think it's so important that we continue to allow people just to arrive. Get your coat off, relax your face. One of the best ways to ground yourself is to put both your feet flat on the floor and push yourself into the earth. Because you're not going anywhere. You're going to be okay. Your feet are on the floor. You're grounded yourself. Your shoulders are down. Your face is calm. It's going to be okay. So let's talk about trauma-informed care. If there's something I say that bothers you, upsets you, walk away. Come back in when you're ready. Don't want to confine anybody to where they don't want to be. The 6 principles of trauma-informed care. And I have handouts up here, but the number one principle we all want to recognize is safety. We need to create a sense of safety for our consumers, clients, patients, and staff. We need to protect them from further harm. If we know that 70% of the people in the country have experienced at least one traumatic event, then most of the people that we deal with, including ourselves, need to be protected from further harm. We want trustworthiness and transparency. We want to be open and honest with our communications, even if they're painful. We want to use the voice of lived experience. I know here at Red Oak, I run a trauma team, and we have folks with lived experience on the team that are community members, school members, clients of Red Oak specifically, but we value that lived experience. Collaboration and mutuality, working with individuals as partners and certainly respecting their perspectives, even if they're different than our own. Empowerment, voice, and choice. We want to give people a voice and control over their decisions and their care. And of course, respecting historical, gender, and cultural issues, recognizing that everyone has a unique background. And one of the best ways to get to know each other is to ask, tell me about it. Tell me about your life. Tell me about your background. So putting some of these elements as, from theory into practice, we know what the principles are. So how do you practice them? How do you put them into where you work, whether it's at Grace House, Red Oak, or SUMA? I see a lot of SUMA. So building safety and trust. If you want to really build safety and trust, there's a few key things you might want to do. So introduce yourself clearly. I put my name on the board up here. It's not very big and my handwriting is not very good. But I want you to know who I am, because some of you can walk out of here and go, what was her name? You told me your name and I don't remember. Everybody does. It's okay. But tell people who you are. Use calm, non-threatening body language. Ask permission before touching anyone. I did not ask permission for some of you because I'm a toucher. Somebody once told me, I used to be a school-based counselor, and I worked at Jennings up in North Hill, close to where Grace House is. And I grew up in Bath. Now, I grew up in Bath. I'm 62 years old, so it was country back in those days. But I grew up in Bath, and then I got put in Jennings. Okay? Whole different world. Didn't know a lot about it, have never been exposed to multiple cultures. I grew up in a pretty homogeneous population. So when I got there, somebody told me, when you touch a student, you may be the first person that's touched them all day. All day. And these are kids, middle school kids. No one has touched them. So I never forgot that. So I touch. But one thing I don't do well is I don't ask always. And not everybody wants to be touched. Some people like it because it makes them feel seen. And other people shudder because it makes them feel traumatized. Provide clear explanations of what we're going to do. This is what we're going to do. This is how it's going to go. Do you have any questions before anybody does anything? Respect patient privacy and certainly boundaries, just like you respect your own. So building that trust. Recognizing signs of trauma. Beware of potential trauma triggers, loud noises, sudden movements. We took our granddaughters to Disney on Ice this past weekend. And God bless you. It was so cool what Disney did. Was anybody else at the program this weekend? We took our kids when they were little, and I thought, the last time we left that building, I said, we're never going to have to do this again. This is awesome, But lo and behold, here we are again. So we took the girls, and what Disney did was incredibly trauma-informed. When the program was about to begin, they got on the mic and they told the kids in the audience, and the adults for that matter, we are going to turn out the lights during this program. And this is what it looks like. They turned the lights and turned them right back on. They said, we are going to have loud noises, and this is what it looks like. And they had a loud noise, and then they did some fireworks. They showed all the things they were going to do before they even started the show, so that the kids, and most likely people that get triggered, knew this was going to happen. And I thought, that's how you do it. So beware of potential triggers. Observable clues like anxiety, withdrawn, hypervigilance. Ask open-ended questions. You guys are all smart people. Asking whys will get you nowhere, but asking, tell me about it. Tell me more about that. Tell me how you feel. Those questions are going to get to where you want to go. Talk about past experiences very cautiously and with sensitivity. All the things that you guys already do. One thing that I added was screening. Do you all screen for trauma when patients, clients, consumers come in? Yeah? Tell me what you do.
We have a delirium questionnaire. We also have
awesome.
There's 2 other ones that we do as well that we just put into play for anyone who comes into Grace House. And we ask them that within their first 3 days of getting there.
What do you do with the information?
Right now we're logging it.
Okay.
We're going to use it for data,
Yeah.
for studying that in the future, especially with delirium and agitation.
Do you talk to the people about the results of the screener? Do you let them know this is what we see, and we're looking at somebody else? What do you do?
Only if there's an issue at this point that we would need to follow up on.
Okay.
So the goal and the hope is that we'll get the information. If it changes too much, we would be able to notify the proper people like a social worker or a community health worker if those things were needed.
Okay. Thank you. Thank you. Here at Red Oak, we screen for what we call ACEs, Adverse Childhood Experiences. We use the ACE screener. So every person, adult and child that comes into our organization, they do get a screener. We go over what we see. We don't screen again. This is the only time they will get this screener. Trauma screeners are only done once, and generally at the beginning, when they come in, within the first 1 to 3 sessions. If they're little, we go over with mom and dad what we found. If they're big kids, the teenagers, we talk about them and with their folks too. And we get adults, we talk about it. We do screen for other things like anxiety, depression, all kinds of things, behavioral scales, those kinds of things. But with the ACE, we only do it once. I do have copies of the ACE. Anyone is allowed to do this. You don't have to have an MD, an RN, or a LSW. Anyone is allowed to do this. Obviously, we want everyone to do it with sensitivity, of which it was designed. It's a 10 questionnaire. Has anyone ever used it or taken it? Okay, so we have some people here that are very familiar with it. Of course, the ACE has been expanded since the original study to include all kinds of other things that we know exist in the world that traumatize people. But this is the original 10-question ACE. I do have copies. Please look at it. If you feel you want to take it, you can take it online. If you want to do that, it opens up unresolved issues and resolved issues. But we do want people to know that trauma is what happened to you, but it is not who you are. I've met people with 8 as an ACE score, and they're functioning beautifully, beautifully. It's a 1 through 10. So you are not your score, but it is important for people to recognize what happened to me when I was little is not my fault, and I can move on. But I may need support, or I may just, in my opinion, need to know. So this is a great way to do it. So I have these, and I encourage everybody to screen for trauma. So a patient-centered approach: empower our patients by involving them in decision-making, respecting their autonomy, certainly validate their experiences, and offer support and coping mechanisms. Do you all have things that, when you're talking about tough things, whether it's medical, whether it's emotional, do you have things, simple things like stuffed animals, fidgets, anything that a consumer or a person can hold and touch or hug while we're talking about tough subjects? Say it again, I'm sorry.
Give them my hand.
Yeah, I love that. I love that. They can't take it with them, but they can have it while it's there. Yeah. Even adults benefit from having something to hold, something to comfort. There's all kinds of things that people can use. We have acorns, because we're Red Oak. We have these cute little stress balls that are acorns that the kids, they just work them. We have all kinds. We used to have the fidget spinner things that drove every adult crazy. The kids loved them. But we even have stuffed animals downstairs. You can hold it while you're talking. So staff training. Provide regular training for all staff members on trauma-informed care. Your sweet Holly said, hey, Ann, she called me up in the summer. She said, this is what we need. We are going to have a 5-part series that we're going to do for you all. This one is here at Red Oak. She asked that the rest be over at Grace House. If you like it here or want to come back, we can switch it, whatever you want to do. So we're going to provide some training. We're going to talk about all kinds of things that Holly came up with. And you're going to have that once a month today through May. Foster a culture of understanding and empathy towards trauma survivors within your organization. And that's an important key part about being trauma-informed. When we talk about trauma-informed care, we're not just talking about the people that come to us for care or the folks that are at the end stage of life. We're talking about all of us too. And that sometimes makes some people very uncomfortable because usually it's top down. We're the top, right? We're the caregivers. We don't want to talk about what's going on with me. I'll talk about that somewhere else. But for a trauma-informed organization, we have to talk about that some of us have gone through some pretty tough times, maybe even just today. You don't know what happened to somebody in this room last night. I don't either. But if I take a trauma-informed approach, I'll open up my mind to knowing that somebody in here probably had a pretty tough night. So your environment, created a calm, welcoming physical space with clear signage and comfortable seating. I tell you, when I first walked into Grace House up there in North Hill across from Pez, because that's where I spent days over at the Psychiatric Emergency Services, and it's not so pleasant over there. I don't know if anybody's had the pleasure. But when I walked into Grace House, it was a breath of fresh air. You could smell the newness of the place, but also it was so welcoming. Is the person who worked at the front desk here today with us? Whoever she was awesome. But it was a very sweet, welcoming atmosphere. Ensure privacy, obviously, during sensitive conversations, and try to minimize those triggers, like the bright lights, the loud noises, those kinds of things. At Red Oak, we are trying to create a wonderful, comfortable space, so when you walk in, Michelle and Kelly are at the front door. They want to welcome people. People are nervous when they come in, and I don't blame them. The courage it takes to walk into a mental health center is beyond something I could comprehend. So much respect. So they walk in, they're nervous. What if nobody says hello? Where do I go? What do I do? Who am I supposed to see? And just all those questions. So we want to create an atmosphere that says, come on in. It's going to be fine. You're fine. Everything's going to be good. Sit in one of our fun chairs. Have coffee, have water, whatever you need. We're going to hang up your coat. It's all going to be okay. That's the atmosphere we want to disarm people and say, this is a safe place. I saw this and thought of all of us who are in the direct service professions as well as volunteers. At first, I was excited to jump into that role as a nurse caring for these patients as I walked through arguably the worst moments of their life. What I didn't realize was that the empathy I provided in those situations was at great cost to myself. Burnout is real. In fact, in Europe, they've created a diagnosis around burnout, a mental health diagnosis, as well as loneliness. Those are kind of the new things that we've learned about people. So being in the profession of helping others, it does take its toll. And we're going to talk about it. The expectation that we can be immersed in suffering and loss daily and not be touched by it's unrealistic as expecting to be able to walk through water and not get wet. We have to recognize that this personal toll is going to happen. No one is immune from it. So, vicarious trauma, secondary trauma, and compassion fatigue. Holly wanted me to spend time talking about this because she loves you and she's worried about all of you. It's a tough subject, but it's very, very important that we recognize not only in ourselves, but also our colleagues. If somebody's not doing okay, that we look at them and ask them, are you okay? You want to talk about it? How can I support you? We want to be able to do that. So vicarious trauma, secondary trauma, and compassion fatigue, they're changes we kind of use interchangeably. There's some slight differences, but the meat of the matter is there. It's a process, not an event. It includes our strong feelings and our defenses against those feelings. It's our strong reactions of grief, rage, and outrage. How many people have ever felt rage at work? Right, yeah, double hand. Double hand. Yeah, isn't that something? And we're supposed to be the most loving, caring people in the whole wide world, but I'm as mad as a hornet. So our grief, rage, and outrage, which grow repeatedly as we hear about and see people's pain, loss, and are forced to recognize the human potential for cruelty and indifference, and it is our numbing and our protective shell and our wish to not know. You guys have been exposed to incredible cruelty, indifference, and inhumane treatment of other humans. Has anybody gotten to the point that you just don't want to know? Don't tell me. I know I have. When I got to the end of the direct service, it was like, and I still do supervision. There are times I had a case, unfortunately, we had an adult die by suicide, and I was reading the chart, and, I didn't want to read it. It was so, so sad. I'm still talking about it, so clearly it had an impact.
I have a question.
Yeah.
A lot of times we walk into our patients' homes, whereas we've seen a lot, for lack of a better word.
Yeah.
Can you kind of talk about counter-transferency? How do you deal with some of the things that you see in our patient's home that kind of like remind us of our own personal things?
What's your first name?
Shaki.
Shaki, that's a powerful question. That's a powerful question. Does everybody know what transference and countertransference, those terms? I would guess you do, but I just wanted to double, triple check. Okay.
You should explain them. Can you explain them?
I can explain.
Yep.
Transference is when, and Shaki, you tell me if I'm incorrect. When clients or consumers project things onto us, it's client directed at provider. Countertransference, like somebody, example, you remind me of my mother. You remind me of, somebody, my teacher, that kind of thing. Countertransference is when we, as providers, have feelings about something that they're saying or going through or living through. So it's coming from us that it sounds like triggers us because we're in their homes going, wow, this is familiar. And how do you get through that?
Yeah, how do you kind of like work through that?
How do you work? That's a tough one. That is a very challenging situation. I think recognizing that you have those feelings is the first step. Being able to find someone that you can share that with. Do you have a colleague or someone in your support system that you can say, I went to somebody's house today and it really upset me. Mm-hmm. Can I talk about it?
Yes.
You do have that. You do have that. I think also recognizing what that triggers in you, what adverse childhood experience does that bring back to you, and working on how to develop resilience and coping against those memories. But the first thing I love that you did was even recognize they're there. Does anybody else have something that they can share or a similar experience?
Oh, I think there's nothing wrong with saying I can't do this.
Oh, no.
Finding someone else to take that place, because if you don't solve that issue, you're not going to be helping the person that is. So that's what I've done. I work with the elderly, Alzheimer's, and I'm an end-of-life doula. And if I am with someone that reminds me of my mom or my dad, and watching what they went through as they aged, I just say, I need to pass this on to somebody else. So, because I'm not doing myself any good, I'm not doing this person any good. So
That's tough. Thank you for sharing that. Does that help?
Yes.
Do you have the option of saying, you know what? I did this home visit. I don't know that I could go back. Can I transfer this case to another colleague? Do you have that option?
I do.
Is that a hard thing to do for you?
It depends on the relationship. If I build some rapport with that patient, then obviously I can see the counter-transparency a little bit clearer. But if I start to feel or get triggered by any of those things, during our first initial visit, then I will, pass it on to a colleague or talk to.
I love that.
About it.
Good. I'm glad you guys gave that advice. We can be kind of a hero complex as a group that, nothing's too hard, nothing's too tough. I need to work through it. We can kind of get into that thinking as opposed to, I'm not going to be able to do this. It's too upsetting. And even sharing that with our client or our consumer.
Yeah. A lot of it is like for me, just being like a male, and
Yeah.
and a lot of the times clients, the transparency, a lot of times clients project things on me.
They
You
do.
know what I mean?
I bet they do.
So just having a team to be like, hey, Carolyn, or hey, Ginger, can you take this patient? And they have been,
yeah.
they're supportive. So yeah.
You're absolutely right. The men that work here, when we put them into the schools, definitely the kids are drawn to them, but also the staff. And to just be stronger than is necessary is part of the problem. It's not the answer, because we're not doing the service to ourselves or someone else.
Absolutely.
Thank you for bringing those topics up. That takes a lot of vulnerability.
So to build off of what he said, at times I feel selfish because I'm in the home caring for a caregiver, but yet I'm getting something out of it based on past traumas that have happened in my life. I strive taking care of those maybe who have chemical dependencies and or like those kind of issues in their family, because that's how I grew up. And I feel I bond well with them, and I get something out of it, and I feel selfish at the same time because I couldn't help my family, but yeah, I can help all these others. And I feel better for it. And I want those cases. Does that make sense? I do better there.
Is that selfish or is
I don't
that
know.
healing?
I feel selfish. I don't know. Because I get something out of it too, because I'm open and I talk about it. And I'm tough. I have tough love to give people. Tough. I don't know. Because I get something out of it. I don't know.
I think that's selfish.
So I want to take those things that have hurt me.
Sharing your gift and your knowledge of what you went through.
So I don't know.
I think one thing I've observed working in hospice for a long time is many of the people that work in hospice have gone through very traumatic experiences.
Yes.
And they use it to their advantage to help their knowledge and their coping mechanisms to help the patients and the family members go through a really hard time.
Yeah.
So I think that's using your gift, in my opinion, Melissa.
Your gift. Isn't that a lovely word?
That is. Thanks.
Anybody else?
Something out of it, you wouldn't be able to keep going.
Yeah.
Imagine if you weren't getting anything back out of what was going on. Such a drag.
Thanks, guys. So the risk factors that you and I have in this profession towards secondary traumatic stress. We're also going to get to the good, the positive. It's not all doom and gloom, but I do need you to know the risk factors. So length of service. I graduated from my master's in 1986, so I'm coming up on, 40 years? That could be a problem for me. Those new to the profession have not yet developed effective means to cope, but very experienced workers are at risk because of the accumulation effect of how much they've heard. So our newer people may not have the ability to cope yet, but our veterans may have coped too much. Being aware of that. How many folks have been in the profession you're in for less than 5 years? Okay. How many people 10 years? Okay. 15? 20? How many over 20? So your risk factor, yeah.
I graduated the same year you did.
Awesome.
With my master's.
Awesome. Back in the 80s.
Oh, yeah.
Left my shoulder pads at home. We were big too. They were, oh my, we thought we were so cute.
Yeah, you're too young.
We weren't cute. So, not enough or too much. Veterans, please reach out to the young people because we need them so desperately. So desperately. Young ones, please respect your veterans and ask them, how have you done this? How have you survived? Secondary traumatic stress may be more problematic for the following: people who avoid problems or difficult feelings, folks who blame others for their difficulties, or withdraw from others when things get hard. Now, I'm not asking you to identify out loud, but please pay attention if some of these things do happen. If you avoid, blame others, or withdraw. There are times that I avoid things. I will disclose that. And I always try, is it avoidance or procrastination? Avoidance or procrastination? And I think it's avoidance. I really do. Another concern is a poor social network, a poor support group. They don't have a lot of people around them that can lift them up. They don't have that social network to depend on. Bruce Perry. Has anybody heard of Dr. Bruce Perry? If you want to know more about trauma and you want to know more about neurobiology and how the brain chemistry interacts and gets triggered during traumatic situations, he's your guy. He really is something. So he talks about other risk factors, empathy. You know, what a wonderful thing to have. It's what a gift to be empathetic to people, to really feel what they feel. However, it is a risk factor. Those workers who are especially skilled at connecting with people through empathy are at greater risk. Does anybody in here feel other people's emotions when they talk? And it's okay to say you do. Yeah, we got 2 empathizers over here. Anybody else? Yeah, it's okay. I mean, that's what we do, right?
Yeah, that's what we do.
But it puts you at greater risk.
It does, but I think for me, being empathetic, and you know, I've done this for about 13, 14 years now.
Good long time.
When I first started, the empathy, it was wonderful, and being able to kind of read the patients and the family members, but then as I went on, I started to own, you know, everyone else's guilt and different things and outcomes, and then I had to realize, okay, it's good to be empathetic, and it's good to be able to read the room and be able to be supportive, but it's also good to have boundaries and realize, you know, where that cuts off.
Yep.
And there's a point where you can only do so much. You can't fix decades of trauma, you know, in 2 or 3 visits.
Right. No, you can't. No, you can't. And one of my colleagues is going to talk to you folks maybe next month in February about boundaries, spend a whole bunch of time on how to create boundaries with people that want to overstep. So empathy with traumatized persons helps the social worker understand it may put you at risk for vicarious trauma if you don't have, what's your first name? Lori's boundaries. If you don't have the ability to have emotional, personal, psychological boundaries. I'm not talking about walking out of a room because somebody said something that bothered you, but being able to process that later and say, this isn't about me. Insufficient recovery time. Now, I'm talking to the folks that respond to very serious situations, but it is a fact, if you don't have enough recovery time, you are at risk. Professionals working with people in difficult circumstances are required to listen to horrific situations people have experienced. These same professionals may be traumatized, having to listen to same or similar stories over and over and over. As well as social workers, consider those workers who are supporting traumatized, very ill, and dying people. Over and over. Making sure you have time for recovery. Making sure you use those support systems. When I spoke to you guys last year, we talked about building resiliency, the things you have to do to build resiliency in life. You know, not just in the helping profession, but in life. You building resiliency so that you can hear the horrific things that we all hear every day going on, you know, outside in our world. Building. Who feels they have strong resiliency skills? Yeah, good, yeah.
Can you talk a little bit about what building resiliency looks like?
Building resiliency? Well, one thing I'm going to say that nobody ever likes it when I say it, but I am going to say it, exercise. I know it. It's a tough word. Take the stairs, not the elevator. I know it. Of course, your basic sleep and eating right, but also hobbies and interests, developing hobbies and interests outside of work and sharing those with other people. hey, this is what I'm doing, can I talk about it with you? So that you're not just talking and consuming with this stuff, that you're talking about other things. Having faith in something. You know, AA taught us a long time ago to believe in a higher power, and it's not necessarily a deity. Of course, if that's awesome if you believe in that too. But believe in something, the greater good. There's got to be something that this is all going to lead to, right? There's faith, and hope. Hanging around people that are positive and healthy is an awesome way to build resiliency. Just engage in positive, supportive activities. Who in here has a hobby? Who in here has a hobby? Yeah, who in here is sharing it with other people? Because you got to finish that sentence. You got to share it out. Develop a hobby, develop an interest, something you bring to the table. Does that help? There's a whole list of them.
Carolyn has something.
Yeah.
I'm glad that you touched on AA too, and I was helped by Al-Anon many years ago.
Yeah, great.
And this was after I had my master's and I thought I knew everything.
Oh, me too.
So it was very valuable, and even though I don't attend anymore, and I know that it was all founded here in Akron, I'm
Yeah.
from New England, but the principles of giving it up to your higher power and knowing your place in the world and things like that, and a lot of the sayings that
Yes.
Al-Anon has are,
Yeah.
still resonate.
Yep.
And I share those sometimes with people that I think are struggling, like the spouses of people with Alzheimer's and the families that are struggling with something they don't know how to handle at all, and the trauma as
Yep.
well, but they don't recognize that as grief
Right.
and things like that.
I love
so
that.
you can bring in those principles from AA and 12-step and Al-Anon just to help people. And I've actually referred people at times, to just consider just going online, and seeing if that might be a good support group for you, whether it's substance abuse
Yes.
or
Yes.
something else going on
You're right.
in line that's addiction.
Yep, I often quote sober people, sober places, and that has nothing to do with sobriety.
I'll find the AA and I'm not an alcoholic, just to try to understand it.
It's an incredibly
Write me an lie about it.
research-based. It's wonderful to look up the 12 steps. It's really something. Okay, guys, your own unresolved trauma. Many professionals have some personal loss, certainly traumatic experiences of their own. Pain can get reactivated when professionals work with individuals who have suffered similar traumas that we've talked about. It triggers painful reminders. Trauma needs to be resolved to the best of your ability. Does it ever erase? Probably not, but you can look at it as resolved. And that requires some work. Sometimes it's therapeutic work, sometimes it's building. The antidote to trauma is resiliency. It's building your own resiliency. It's doing something to say, boy, I feel bad, but there's ways of not feeling this bad. And that's getting into groups, individual work, something, but it does take an active participation to resolve trauma. If you don't, and people continue to trigger your own trauma, you'll be vulnerable to those feelings. So isolation and fragmentation. Now, this is a systemic issue that we see at places of work, places of worship, and schools. So let's dive into this a little bit. When individuals feel valued or in the presence of others who respect and care for them, they are capable of tolerating extreme stress. So if you work in an environment with loving, caring people that you feel you can be your genuine, authentic self and say, I cannot today, and they will hold you and love you and say, why don't you get out of here for the day, get out of here. You have a better chance of weathering the longevity of your career as opposed to working in fragmented systems that stress individual working. That, you're responsible for the work. There's not a lot of team interaction. There's not a lot of support from administration. There's not a lot of support that's going to help you cope with all the things that you're going through. Nobody's coming up to you and going, I'm going to touch you. Okay. Are you okay? Are you okay? There's nobody doing that. There's nobody doing that. Those folks who work in those kind of environments obviously are at risk of not only reactivating old traumas, but my thought is developing new ones. So if a system truly wants to be trauma-informed, they will stress the teamwork, the team coping, the check-in, the arrival, really caring about what's going on with people. Now, some places are just too big to feel that intensely, and other places are so small you feel overwhelmed by it. So it's that balance. So, compassion, satisfaction, contentment experience from being a helper. So we all got into this profession. You know, people say all kinds of reasons why they get into, whether it's mental health, physical health, hospice, what you're teaching, whatever you choose to do. But we know from research that the contentment is experienced, and the reason people do this is enjoy helping people. I really like, how many people in here I really kind of enjoy interacting and helping other folks? Yeah. Sometimes you have to ask yourself that question. It's a hard question. Do I really want to do this? Do I really want to help these people? They're yelling at me. They're irritated. They're ungrateful. Maybe they're physical. Do I really? Probably so. Feeling a part of something bigger, and I think that's where spirituality can come in as well. Believing in something bigger. This is bigger than you. Fulfillment of faith and spirituality. Some people believe I need to walk this walk as a testimony and need to do this. Supporting and protecting vulnerable people. It's like family, right? You know, you really manage your family, but the minute somebody talks bad about them, you're like, no, what are you, you're ready to go. I can talk bad about my mother, but don't you? Seeing the positive changes that can happen in people's lives. You can see. Now, we work with little guys, and our therapists and case managers often will come in and say, what in the world? I'm doing all this stuff. You have a great session with the kid, you send him back into the classroom, and then things just fall apart. And the teacher says, what are you doing in there? Look, he just got back in and was so disruptive. All you do is play with him. What are you doing in there? And it's like, what am I doing? I don't see any positive change. Some of the changes are yet to be seen. Enjoying the challenge, working with a wonderful supportive team, and feeling that every day is a different day. How many people have a really bad day, but the next day you're like, all right, this is the first day of the rest of my life. I'm going to go in with a great attitude. I'm going to do this. This isn't going to keep me down. Or how many people go, yesterday was so bad, I'm going to walk into work and I'm not going to talk to anybody, and I'm just going to do my job, and I'm going to get out of there. Ugh. 50-50. There's an honest answer right there. Yeah, some days don't you just want to come in and go, nobody talk to me. It's awful. You don't stay there, do you? I can see it in your face, you don't. You got a smile that lights up the whole room. I can see you won't. I can see you tell yourself to try, but you won't. Research-based. Finding something on this list that gives you your calling. Why do you keep coming back? You guys are experienced. We had close to half the room with over 20 years experience. You guys are doing this for something. Me too. How many can resonate with that? Didn't even know I could love anybody that much. Even when they're mean, even when they're, not treating you very kindly. And we are going to have some talk in another program about how do you deal with that. How do you deal with family members that are difficult to work with? How do you deal with patients or consumers that are difficult to work with? Here you are, given everything you've got. But could you imagine doing it any differently? You really...
Those are my favorite, the mean ones. The mean ones, to be honest, the mean ones are my favorite.
The mean ones are my favorite. I'd put that up there. The mean ones are my favorite.
And most of the time, underneath that, you know, kind of sharp exterior, they're really just big softies.
Yep.
And they just need somebody, they're testing you.
Yeah, and it's trauma.
They're testing you to see if you're going to continue to be kind.
You gonna leave me too?
Yeah,
In fact,
exactly.
I'm gonna beat you to it. I'm gonna be so nasty that you and everybody else is gonna walk out. Yeah, it's trauma, unresolved trauma.
Exactly.
And some people take the challenge, and other folks, I mean, we all have turnover in our business, right? Other folks just can't. But we can all lean into that love. And my favorite quote is by Mark Twain. The two most important days in your life are the day you are born and the day you find out why. We need to find our why. I don't have all the answers. I just know that what you're doing is a noble cause that not everybody was called to do. So you're doing amazing work. Yes, ma'am.
I think you brought up a lot of stuff that we know, but you validated, and that we don't always talk about
No.
amongst ourselves.
No.
But we may know it,
Yeah.
and we may just need to get in touch with it. And
Hard to tell.
sometimes we need to,
Yeah.
that validation that it's real and it's okay. And, you know, nowadays we used to call it buttons, and now we call it triggers. And,
Yeah,
you know,
okay.
we get constantly poked
Yeah.
at.
Yeah, you do.
However you want to say that.
Right.
you know.
You're right. You're
We all have
absolutely
different
right.
ones, so, absolutely, thank you.
Yep, great. I'm glad we could talk about it because it's not easy to talk about, and it's upsetting to some degree. So, thank you so much.